So it seems that everything is working. So welcome again. So Pavel, if you can, please introduce yourself very shortly, please. Welcome here.
Hi, everybody. I'm a neurologist. I've been working in neurology for more than 15 years, mostly specializing in neurodegeneration and advanced therapeutic modalities like deep brain stimulation or pump therapies in patients where standard oral therapies usually fail. Today, I have chosen a patient out of the list that we have here that could be indicative of something that you, as future doctors, will meet, let's say, in your everyday practice. It's not nothing extraordinary, just an elderly lady at the age of 70 who's been reporting some mild memory problems. Differential diagnosis of patients like these is not that complicated, but there are several important things that we need to consider in such a group of patients before we say that it's Alzheimer's or something similar that cannot be treated meaningfully. Uh, let's say we give up. So this lady mentioned that she cannot remember things like she. Can you see the screen is shared? I hope. Is it?
Yeah. The screen is shared, so I think that the audience could see everything. Yes. So please
Perfect.
continue. Perfect.
So I can't remember things like I used to, and it's affecting my daily life. What's important here is history of depressive episode 5 years ago. Please keep that in mind. Patients with depression, one of the major complaints they usually have is that their memory doesn't work. But when you do complex neuropsychology, there's a very specific finding that points just to certain parts of memory, which and the profile itself is inconsistent with neurodegeneration per se. So let's ask this lady something more. Uh, what exactly were the activities that you feel the most problems in?
It's mostly the little things that used to be second nature, like trying to balance my checkbook or just calculating a tip at a restaurant. I get so flustered because the numbers just don't seem to add up the way they should anymore. And then there's the appointments. Completely missed a lunch with my daughter recently. I couldn't find out why we were supposed to meet, which was just mortifying.
Okay. What do you usually, how do your usual days look like?
I try to keep things as normal as possible, you know? I still play crossword puzzles in the morning, though I'm finding the spelling part quite tricky lately. And I try to keep up with my reading, but I often find myself having to reread the same page 3 or 4 times. My husband usually handles the bills now, which I hate because I used to be the one who kept everything organized.
Okay, this is actually an interesting part of the system because I posed a simple question: how do her usual days look like? And she just returned back to the original complaint, which I wasn't that interested in actually. I was mostly interested in her activities of daily living, but I don't know whether it's a feature of the system, but many patients with cognitive complaints or decreased cognitive performance will tend to focus on the things they want to talk about, which is kind of a bummer, but we need to work around it. So let's pose the questions slightly more
Okay,
specifically.
Pavel. So do you think that you think that this is kind of, yeah? Now we see that she's trying to react to some kind of fragment.
Just hard to accept
Yeah.
that I need
Problem.
someone else
So
to
Can I?
take over these. things.
this kind of reaction is very nature that
Now I feel like I'm
that.
constantly tripping over my own
So we'll
thoughts.
pose a different question, and then I wanted just only to point out that we could also order some tests. So maybe if you really think that something is interesting to order, some laboratory tests, we might try it as well. And in the end of the day, there is some kind of like another feature. It is called physical examination. So you could try to get the current values of like blood pressure, SpO2, and something like that. Yeah. So sorry for interrupting. Let's see.
We will get to that. I also think that, let's say, jumping to physical examination and ordering tests often isn't the best approach. When you are pressed that you have 10 minutes for a patient, it's the only thing that you can viably do. But in people who have had complaints like this, just talking to them, actually they prefer doing that, and you will get more information when talking to them, because we will go through her drugs, we will go through her medical history probably. She won't probably remember what she's using regularly. She will tell me that her husband has been preparing her drugs, but I need to know when she has some complaints about her memory, how she is able to handle simple questions. So that's why I went for her usual day, what she has in the morning, and I was just focusing on the system, how it's able to handle something like this. So let's start. We can skip. What I would do here, I would just go through her usual day, then ask about the history of the disease, because usually when you have a patient and you just over focus on a pre-scripted interview, patient usually wants to talk about the things that that bother them now. And if you just skip immediately to the history, to the list of drugs, to the list of diseases, they feel kind of cheated. So, but let's see.
Okay.
When did the problem start?
It's a good question. Honestly, it's been a gradual blur. I think I started noticing real trouble about 6 months ago. Or maybe it was last autumn. Everything just feels like it's slipping away faster than I can keep track of anymore.
Okay, that's an important point for us, because we know that we are handling something that has been on for more than 2 or 3 weeks. The differential diagnosis will lead us somewhere, because if we had a patient who has had problems for 2, 3, 4 weeks, it could be mostly internal medicine based, it could be slowly progressing delirium, it could be in an elderly lady like this, if she's using antiplatelet therapy, it could be subdural hematoma or something like that. But now that we know that it's been progressing for well over 6 months, maybe a year, we are in a different area. But let's go to see how well the system handles the patient. Let's go for the physical examination. There's a button here. So let's do the full neurological examination. So let's do the full neurological examination.
Please specify which part of the neurological examination you would like to perform, such as cranial nerve testing, motor strength, sensory assessment, or a formal cognitive screening tool.
Okay, the software is picky. Let's do a basic screening examination.
Please specify which specific cognitive screening tool you would like to administer, such as the Mini Mental State Examination, MMSE, or the Montreal Cognitive Assessment, MoCA.
Okay, so it's pushing us somewhere. We don't like that. So I want to do full cranial nerve testing, sensory assessment, motor strength.
Okay, let's see.
Cranial nerves 2 through 12 are intact. Motor strength is 5/5 in all extremities, and sensation to light touch and pinprick is symmetric and intact throughout.
Okay, so screening is here. It's okay. What about any signs of hypokinesia or rigidity?
There is no evidence of resting tremor, bradykinesia, or cardial rigidity upon passive range of motion of the upper and lower.
So we have no motor affection, no problems in the basic screening. So we are away from the movement disorders and get into just the general cognitive disorders. So since it provided us that option, let's do the MMSE and FAB.
On the MMSE, Mini Mental State Examination, patient scores 22 out of 30, with errors primarily in recall, calculation, and orientation to time. On the FAB, Frontal Assessment Battery, she scores 12 out of 18, showing particular difficulty with word fluency and the motor series tasks.
Okay, so we have, sorry about that. Okay, so we have,
please specify which aspect of the clinical findings you would like to discuss, or indicate if you wish to proceed with further examination.
Sure, we will.
So we have mild cognitive impairment that's not purely mastic. There are also some dysexecutive problems, so mixed type. The things that we should expect now, we should go for some basic path work because it's pretty cheap, it's quick. We can do it virtually immediately and then we'll schedule some imaging. So we'll order some tests. Let's go for simple complete blood count. Let's go for, what do we have here? Basic metabolic panel to see how the kidney and liver work.
Okay.
Let's go for, I want to have this one, not that I think that cholesterol would cause a huge problem, but basically even if it's pure Alzheimer's, there usually is a part where metabolic syndrome confirms the disease, so we need to know how it's being handled and whether we need to do something more. We can go for these ones, just to be sure. And where do we have blood glucose? There's the blood glucose. Then we would want to have thyroid hormones, even though the cognitive profile isn't really suggestive of hypothyreosis, but they are not here. I cannot see them. Well, they should be here. Never mind. Not here yet. Will be added, probably.
Yeah, or maybe that they are in a little bit different category.
Mystery. I don't see. Here it is.
Yes, exactly.
History. So it's not endocrinology. Never mind. That's the usual stuff you will find in any hospital information system that you will be looking for through the request forms to search for something. Let's give the lady a benefit of doubt, but in patients like these, STDs could be a major point of interest, but it's a stigmatizing thing to ask the patient like this for an HIV test, but if everything looks suspiciously okay, I would do that. For the Gs, everything is okay. And now let's go for the MRI, and we would expect probably mild hippocampal atrophy, possibly cortical atrophy, and let's see how white matter is in deep regions. Yeah. So
You're right.
this is actually pretty consistent with just the hippocampal atrophy. I'm pretty surprised the other parts of the brain look okay-ish in a patient like this at the age of 70. If I see a brain like this, that's a younger brain. But yeah, we're still working with an AI tool, so I would be really surprised, honestly, to see just this mild atrophy to cause something like this. But hippocampal atrophy, when the other parts of the brain are okay-ish, is highly suggestive, let's say, of Alzheimer's at the beginning. So the easiest answer was actually the correct one.
Mm-hmm.
Okay, one more do we have here just to play around? Do we have neuropsychology and psychiatric examination? Let's see. No. Let's see. Physical examination. Let's do MADRS and BDI2. Those are screening tools for
The MADRS score is 8, and the
depression.
BDI-2 score is 7, both of which are within the range for minimal or no depressive symptoms.
So we have successfully excluded the majority of
Mm-hmm.
internal medicine associated cognitive declines that are reversible. Depression isn't of concern now, but I would still start this lady on SSRI or some mild antidepressant due to the organic nature of the depression that will be probably developing. 80% or more than 70% of Alzheimer's patients do develop over the course of the disease depressive symptoms, which is not surprising. It's biologically driven, secondary, and also when you feel that your memory is disappearing, you will not be happy about it. So
Sure.
there are multiple factors here, and we can start a lady on some acetylcholinesterase inhibitors, but those are not disease-modifying treatments.
Mm-hmm.
We just based on the study that you pick, they slightly slow down the progression of the disease. We can recommend her to do exercises, to do cardio. There are studies showing that people who are active, even with neurodegenerative disease like this, uh, the progression of the disease is much slower. But in this patient, there's no metabolic syndrome. White matter seems okay in the deep areas.
Well, just we are working on the second part of a treatment module, but
Okay,
I wanted just only to share with our audience the latest function, and the goal is to of the system is provide the evaluation. So if we can now close the tests, please, then
okay.
green button on bottom, and this is submit your diagnosis. So here we can just simply guess or provide the right diagnosis. Okay.
Alzheimer's disease. Let's do this.
Okay, perfect. So the correct diagnosis is which one? Other and unspecific symptoms involving cognitive functions are dead. This is the hard one, right? Okay. And what is the system is now doing is now having look at all the information that we provided, and here we are. This is our scoring. So if you can just only briefly go through and just make your comment how it looks like to you. So you got 7 out of 10. So this is really good job. Congratulations.
It's not so good. Student prefer neurology after history taking rather than early to out red flags. Oh, I must say that I disagree with this one because there's a patient who has had problems for 1 year. There's no risk of delaying, and you are treating the patient. You are not treating the neurological examination. You're not treating the blood work. So you need to find out what's their main concern. So even in your clinical practice, don't overdo it with the examinations. We have to find out what are the drivers of the quality of life of the patients, and definitely it's not increased tendon reflexes or something like that. Fail to provide summary diagnosis or closure. Oh yes, yes, we need to do that, but I wasn't really talkative with the lady. So yes, after you have the diagnosis, you have to, or even after the meeting with the patient, at the end, you have to provide something tangible, either the cause of treatment, the prognosis, or the things that you will be going through. But we went through that without just telling the PC that we're going that. So wouldn't be too worried. Do we have the diagnosis? Alzheimer's expected. Signs involving cognitive. Yeah. Okay. R41-8.
Yeah, there is some kind of like a raising concern for possible Alzheimer's disease. So it's unspecified.
Of course it is. It's still early. Minimal registration of storage in Korsakoff syndrome. We would have something in the blood work, which we don't have. Depression, we went through some scales. Frontal lobe dysfunction, there is frontal lobe dysfunction. Pretty good selective recall test. We did FAB, so no really. And as I had a look, there's no MRI PET imaging. We hear that we would have. There's nuclear imaging. There's you can do amyloid, beta amyloid test, or some other that are actually not available in the Czech Republic as of now, which are diagnostically more informative. But even if we didn't have the correct diagnosis, we exclude or didn't have the correct diagnosis. Uh, it's prodromal or early Alzheimer's disease based on the cause and the findings. We provided a therapy that's the best that we can do, and we excluded things that we can actually where we could do some or where we could really affect the disease course. So I wouldn't be too worried. CSF biomarkers, yes, depends on the guidelines, but yeah,
Because the system should provide you the name of the guidelines. So maybe if you go scroll it a little bit down, even more. So this is performance by domain, clinical checklist. Here are there some kind of guidelines like NICE, NG 127, and there are another guidelines CG 150. So in your opinion, are these guidelines appropriate here?
Well, I went through this one. I wouldn't really start early about this because then the patient feels disconnected. They come to complain about the problems they have now. And if you force them to talk about something or what happened 10 years ago, because many of these diseases are insidious, they develop over long years, they might not like that. Screen for immediate Rex early. Signs. No, I wouldn't call that immediate red flag. The issue here is that once again, it was a disease that was progressing over a year. So if it was somebody who was transported to emergency department with sudden onset cognitive problems over the last 2-3 hours, definitely we wouldn't be talking easily like this. But if it's a year, I wouldn't really prioritize those. I would just try to get the patient to talk about what they feel, what's the issue that they perceive. Because basically we can help them with anxiety, with depression, with other problems of psychiatric nature. It's not always that you have just memory problems. We should focus on those. Covered the important background history. We didn't do many medical history, to be honest, and we should have, but time is pressing, so I was kind of cheating, let's say. we didn't check any medication allergies. Oh yeah, we should have done that. But once again, time was short because there are many medications that can
Mhm.
actually increase cognitive complaints. But yeah, my bad. Should have done that
No,
definitely.
you did great. Yeah. So just adding the final recap, and then you should have received like 8 or 9 points out of 10. So congratulations, Pavel. Thank you very much for your time. It was very illustrative, very interesting this case, and thank you to the audience because today it was just only this case. I am looking forward to seeing you at the next time where we present another interesting case from our community. So thank you very much and bye-bye. And thank you, Pavel, once again. Bye-bye.
Bye bye.